Hi, I'm Smriti Khanna,
Hi, I'm Mahesh Menon.
and we are on the Living Well podcast. And our guest for today is Dr. Kiran More.
Thank you, Dr. Smriti, and thank you, Dr. Mahesh. First of all, it's an honor to come on a Living Well podcast. You guys are doing fabulous job to increase awareness in the very unique field of palliative care. So thank you again.
Thanks. Smriti, Kiran and I go back a long way. We've been in medical school together. And I believe he did his post-graduation in Gujarat. I did my post-graduation in Gujarat. He left for Australia, if I'm not mistaken. And then he went to the Middle East.
Oh.
And then he's come back here. So can you just describe a bit of your journey in the world of pediatrics?
Sure. So, well, I did my post-graduation actually in India, but then I spent some 2 years in intensive care in Gujarat. Along with my wife, she was doing post-graduation there. And then I was always aspiring to go abroad. I was trying UK and I ended up in Australia. And I did my formal training in neonatology in Australia, so the whole advanced training. So I board certified neonatologist in Australia. Then I was also interested to go to other part of the world, which is North America. So I end up going to Sick Kids Toronto for my cardiology
So you
training.
went to North,
Yeah.
so Australia, then you went to Canada.
Canada, and then I was trying to come back to again Australasia, and I happened to end up securing job in New Zealand. So I was a consultant in New Zealand for a few years. I was also a director for the South Island Transport, and then I started thinking to come back to India, where I sort of moved back with my family to India. But I did a stopover in Qatar, in Middle East.
Now, how many years were you in Qatar for?
I was intending for 2 years, but due to COVID, it extended almost over 4 years.
4 years, okay. So you've so if we were to understand this right, so as a pediatrician initially you trained, then you did your intensive care training in Gujarat, then you went to Australia, you became board certified in neonatology, and then you've been to Sick Kids Toronto, New Zealand, Qatar, and now you're back in
Yes.
India,
Yeah.
and now you're making reels.
Well, I thought, yeah, I know that has more potential than the private practice. I realized.
So I remember माँ बाप ने पढ़ा लिखा के इतना किया, now you're making reels. So tell us if something very very interesting that you mentioned. So as a pediatrician, and you said neonatology, and you're board certified in neonatology. So there'll be listeners out there who wouldn't understand what the specific term means. So you have different terms in pediatrics, like you say infants and toddlers and neonates. So how can you give us just a breakdown of the terms that we use?
Sure. So newborn is a very niche specialty. So we look after babies who are just born and within first 28 days. And why this period is separate? Because newborns are not a miniature adult or peds. They have a very complete different physiology, and the diseases we deal with are very different than the older kids. That's why it's a separate niche. So we just focus on first 28
So the
days.
first 28 days as a newborn is very different from relatively as compared to the rest, even in pediatrics.
Yes,
as
absolutely.
We know that. Okay.
Yeah. And that's why, I mean, and then we go a little further because we deal with extreme premature babies. So we are actually dealing with fetuses who are born early. So that is a whole big sort of specialty now within neonatology, caring for extreme premature babies.
So they are born before time,
Yeah.
and these premature babies, and there is this premature babies. You have in the newborns, like the first 28 days of life, and then so on.
Then the infants and
Then
the toddlers.
infants
Yeah.
and so on.
Yeah.
And that is where I encountered Kiran, because we were working together after he finally decided to decided to come back to India. We met each other in the NICU. We had already an established palliative care unit in
Correct.
the hospital. I think by the time you joined in
correct.
22. And so our unit was about 2 or 3 years already in practice. And in fact, I remember you were quite surprised that there was a big palliative care unit already in the hospital at that point of time.
Yeah. I mean, absolutely. When I came back, I thought, talking to my clinician friends, they were saying palliative care is like nobody's practicing or they're not even involving. So it came as a really pleasant surprise that there was a full team who was supporting the NICU, and like not only clinician, nurses and social worker and the psychological, clinical psych, everything was there. So I was actually pleasantly surprised to have that team.
Correct.
But what has your experience been of, since you speak about working in so many different countries, what has your experience been of how palliative care is accepted or even practiced in all these different areas?
Yeah, that's a good question because I mean I can divide my experience into Western world, Middle East, and India. And so when I went from India to Australia first time, and again Canada or New Zealand, the palliative care services were pretty well established. It was like a routine,
Even for neonates.
even for neonates. And again, it was new learning for me because we didn't practice that while in India. We used to probably send the patient just home, but it was very well established, and not only the clinician but the nurses and even the acceptance from the family was very well. Then also the support system was there from the healthcare, and even after discharge to follow them up, or if you're going sending somebody on home healthcare, there was a hit home in the hospital system was there, which was pretty again well geared.
And, sorry to interrupt you, but is this a private sector or
No, it's a public sector. So that the main difference was it's publicly funded, so no burden on the family, completely taken care of and fully supported.
Okay.
So family has to just decide for the baby, and rest all is taken care for them.
By the state.
Yeah. Then when I moved to Middle East, Middle East was in a transition. First of all, it was Greenfield Hospital, a very brand new hospital, and as most of the Islamic hospitals, culturally they don't believe in doing abortions or terminating the life, because I think in Quran it's not sort of permitted. So there were a lot of hesitation to start palliative care services. So first 6 months, 1 year, in fact there was all this writing of the policy making and all those things were there. In fact, one of my colleagues' wife was a lawyer, so she was writing the policy for the whole Qatar, and they went through a lot of literature, spoken with a lot of religious gurus, and then they came up with a consensus, okay, we should have this service, and then it established. But again, there was a lot of resistance within clinicians, so Western trained people were very much for it, and some of the Middle Eastern clinicians were hesitating to sort of redirect care. So it was a really good experience to see that transition happening, and by 2-3 years or 4 years I was there, it was pretty well set. So, and then when I came back, as I said, I was not expecting we'll get a support, but I was pleasantly surprised. But that was, I think, that hospital was pretty unique in that support system. But in other places, I think it's still not well established. So we are still in infancy for palliative care services
But
in
I
India.
really liked how he's talking about how in the Middle East they assimilated policy. They spoke to all the stakeholders involved. Like, this is what we say when we say, how do you make a policy which is more inclusive? It will be much more easily accepted. So they spoke to religious scholars.
Correct.
They
Culturally
got lawyers.
appropriate.
They did culturally appropriate is the buzzword, right? Is the
Yeah.
terminology.
But I've seen this in our experience with the Middle East. One of the things that I've seen is that and it's not just applicable to palliative care, it applies to a lot of domains of care. Where anything that seems to kind of be at variance with cultural norms, they kind of involve everyone. The community is involved.
Yeah.
And at the end of the day, the best part is that they all know that it's being done for the greater good. It's being done for everyone.
Yeah.
So I think once the intent is clear and there is vision, then a lot of things fall in place. So the mechanisms are there to
Correct.
help that happen.
I think that is what worked even for us when we practiced together as a multidisciplinary team. The fact that yes, we had a policy which involved a lot of stakeholders who are important, but we also did a lot of patient-centered care. You're speaking about social support, no? Like the state-sponsored social support that is there in the Western countries, even in the Middle East. I think they have a lot of backing or support by the government. But we don't have that here in most situations. We will get financial help, but not for long term.
Yeah.
And I think that is what then becomes culturally appropriate palliative care for us in our scenario.
Within our limitations,
that within our resource limitations, keeping in mind what is important for the entire family and not just that newborn child. That is how then we move forward in caring for that child.
Yeah. And I think in India, biggest is the resource constraint. So resource allocation plays a major role. In government setting, the care might be free, but then the systems are overburdened. So there is always pressure to allocate resource for the needy one. And in the private, the problem is the financial resources from the family, because they are bearing the whole cost. That makes a huge difference in these services.
So there is always some amount of resource constraint
in both settings, wherever you go.
So I never thought of this question, and it just came to my mind right now. So, what's the status of newborns and premature babies when it comes to insurance?
Yeah.
Does insurance in India and abroad, what is your observation? Does it
So
cover?
unfortunately, almost 90% of the insurances in India don't cover newborn because it's an unborn child.
It's
Only,
an unborn, no identified.
They don't exist in the policy, and only the
Right.
corporate do cover the neonatal care, and
This
that is a
something
problem.
new,
Yeah.
And you may not always get a policy for yourself when you are 25, 26 and having
Yes,
a baby or
any-
whatever,
Yeah,
less than 30 years
unplanned
of age.
pregnancies, and also if your policy is not has a waiting period. Suppose you just take and you deliver within a year, it
you're
doesn't
still not
cover. You're
covered.
still not covered, even if good policies. Slowly, it's picking up, and that's I think a big gap, and that is where we also struggle to support the families because many of them, 90% you can say, is non-insured.
So they're paying out of pocket for
Yeah,
care.
yeah.
So what I next wanted to ask you about was, and this is something that we have both worked together on. When we worked together as, or rather as a neonatal team, as an NICU team, that is the neonatal ICU or the newborn ICU team, what actually makes you think of calling upon the palliative care team? What situations, what conditions that you are faced with?
Right. So again, I mean, it's a good question. We generally, I mean, there are broadly few scenarios where straightforward, as a neonatal team, we get stuck. Suppose there are certain genetic conditions where the outcome is not uncertain. You know how the child will survive or not,
Yeah,
and how it
yeah.
will do. Then second big group is the extreme premature group, periviable gestation group, and
Sorry, can you just break that down? Periviable gestation, what does that mean?
so babies born too premature and limit of viability is little bit gray zone as per every clinician's perspective is like, so what cutoff you decide this baby is viable or not. So when
they'll
I
be able to survive on
survive or not. So when I did my residency, even below 28 weeks, we were thinking not viable. But now
So baby born
born
at
at 26,
lesser
lesser
than
than 28 weeks,
weeks
considered
of
as not
age.
viable. So you don't even think about offering any care, which is that limit has moved down to 24 weeks. So we 34 now. So we end up caring a lot of these premature babies, but the complication risks are higher. And sometimes again, you know, parents might, or the baby gets a lot big bleeds, or they are very sick. Sometimes you decide to go for palliative care to support the family.
Mentioned the two. The first one you mentioned was the genetic conditions.
Yeah.
The second was these
Extreme
periviable.
paradigm. Then the birth, the brain injuries, so birth asphyxia or brain malformations, severe seizures, where again you expect that baby might be developmentally abnormal as the baby grows, and or the care of the baby might take a lot of efforts from the families. Again, so there are certain other conditions apart from brain which involves a lot of complex care and support needed to the family, where again in India families don't get that. So there also we involve palliative care again to support this family because they might need help for few months or years.
So it's also your. It's not just the factors around the child's health. It's also around the family's circumstances, that palliative care comes and helps them.
Correct.
So you identified and you feel that this family might require extra support.
Extra support, and sometimes, you know, babies are in with us for 2-3 months, then the families are breaking down either financially or that mental trauma. They need a lot of psychological, emotional support, where I think the palliative care services does fabulous job to support them, because as a clinicians we tend to focus more on medical part. We may not, you know, be able to handle that.
Yeah, so the team, you have everyone in the team has some designated role, and that's when you call upon them.
Correct.
All right.
And this, I remember seeing a lot of babies with extreme prematurity, so to speak. Do you have any patient stories around them?
Sure. I mean, lots of them, in fact. Lots of them, good and bads. But, you know, you always get pushed with your limits sometime, you know, and because I come from a Western background where we were caring for a lot of extreme preemies. So my outlook has always been very positive.
Just a quick question. Extreme prematurity means, is there a cutoff on the number of weeks?
Yeah. So different countries have different cutoffs. So in India, I think many clinicians and pediatricians are comfortable to support the babies beyond 26 weeks. 24 to 26 is kind of a gray zone where most of the neonatologists we want to support, because a lot of these babies come out nicely and, you know, they're breathing. So you feel like you feel obliged to care.
Yeah.
And we have seen a lot of good outcomes. I have even 22, 23 weekers doing pretty good. So you know, you're obliged to care. So but it again depends on the parents' wishes or obstetrician's wishes here. Is it a primary or secondary? What is the situation? You know, how
There are many
the
factors,
many
I guess, that
factors
go
around
into
it. And then again, the insurance we spoke about, whether family is able to support financially a stay of a premature baby for 2 to 3 months. So that all factors always pushes us to decide to support these babies or not, for and against. And many times we start off caring for these babies, but then they end up getting complicated. They get serious NEC, like infection in the tummy, or bleed in the brains. Then you know that, you know, the effort might be a little futile. So within we sort of go to the palliative care pathway. But recently I was pushed to my limit, you know, when a very critical situation, 45-year-old mom, and 9 years they have been trying for IVF, and multiple failed attempt, and they conceived a twin pregnancy. And she had a issue with os being opened, and then she went at around 21, 22 weeks, her os opened, and there was no way they could, you know, stop the labor. Now I called, you know, to whether should we do it or we consider. Now this is clear cut before viable gestation as per the Indian norms. So before 24 weeks, you don't want to, you know, even attend the delivery. But the obstetrician requested, because parents wanted to support. It's a precious pregnancy, last chance. She may not conceive again.
Yeah.
And then we had a discussion, and then parent is coming out with Google news showing me like, okay, this baby survived at 22 plus 5 in India, in Mumbai, in Bangalore, in Hyderabad. He's coming out with a lot of and putting me under pressure. And I said, look, I mean, I have my own 22 plus 6 weeker who's doing well now, 13, 14 years old, little bit delays, and you know, I follow him on Facebook because he's in Australia, but doing well. So there are good stories. So I said, well, look, I'm ready to try if you are willing to this support, but we have to agree on certain things, like baby should be at basic or certain weight where we can, at least our equipment will support. So we before delivery agreed that maybe the baby's weight maybe 450, 500 grams, then we'll do a full support. Now baby delivered.
So talking about 500 gram.
Yeah, like small babies, are very small, like larger than your iPhone, just little larger than palm size baby. So baby delivered, and immediately I put the breathing tube in. Baby recovered within 2 minutes. Baby's heart rate and respiration was normal, and then we put the baby on a weighing scale. It was 350. Now it was such a big dilemma, almost for 1 hour, and then the second twin came was 320 and was not in a good shape. So we have this 350 grams baby, and who's actually breathing, normal saturations, and now we asked family what to do. Then because the weight is so small, and they probably have to spend 4 months in the NICU and all those things, and no assurity about any outcome. They said, what's the guarantee? I said, like, I cannot give you anything with this weight. So we had like almost an hour discussion, and then obviously, and unfortunately the husband had not reached. He was in Middle East. So on the phones, and then ultimately they decided we'll not continue, because again, a lot of financial impact with no guarantee. And we had to sort of go for palliative care pathway. So that was very difficult. I don't know. I mean, I don't know whether I should have continued or the family. If I wish we would have had a free health care, probably we would have continued here. But we did not. But sometimes, I mean, there are other stories, you know, which might be more interesting. Sometimes, you know, like we feel we know everything, but sometimes the nature decides, you know, and some babies always trick us. So there was another in my previous hospital, another story I would like to share. 24 plus 5 weeks, close to 25 weeks baby, again 600 grams. And families were for everything. They were like, we are ready for everything. We cared for this baby and had a little bit of bleeds in the brain, but the lungs were pretty bad from the beginning. And after third, fourth week, the lungs become so difficult to ventilate, and then baby had multiple episodes of infection. It was just difficult to ventilate. The babies was constantly desaturating, like not maintaining oxygen levels, and multiple discussion happened with the clinical teams and the family. And ultimately we said, okay, I think we have to go for palliative care pathway. We don't know where we are heading. We can't allow the baby to be so hypoxic every now and then and may not have a good outcome. So family ultimately agreed, and we went for the final ritual. They did their all rituals and this thing, and we said, okay, let's do a final cuddle of the baby. And then so we got the mother in with a chair and we put the baby on mother's chest. We said, okay, just do a little bit of KMC, faddle, cuddle, and then we'll redirect the care. And when we put the baby on the mother's chest, the SATs went from like 70% boom, boom, boom to like 90-95%. Like, I was like, oh my goodness, what is going on here? And then it lasted, like we said, okay, stay there. And almost for the 2 hours, mother was cuddling. The SATs did not go down below 90%. Now you're in a puzzle where you have written, signed all the documents for DNR, DNE, etc. So do not resuscitate and do not escalate. We decided not to offer anything, but baby was ventilated. And then we said, okay, look, and again, as a lot of clinician, as you know, the prone ventilation works in bad lungs.
Yes.
Even in COVID, I think was tried.
Yes.
So we do sometime, but premature babies are very difficult to prone and do this thing. But the position in which the baby was the best position for ventilation.
Yeah, it's similar to, by prone you mean just when people are put on their tummies and they're put in ventilators, they survive
longer. So that was happening, and then we said, okay, great, this is working. So I said, can you stay longer? Like, so she stayed for another 4 hours, 6 hours. She was in the NICU, and baby remained okay. So we said, all right, fine. So we created like a prone situation in the bed.
You modified
this thing, and then baby was maintaining 85-90. Then we told mom, like, maybe you just come in and we do prone ventilation every day wherever you possible. Come and do KMC, and she continued for next 1 or 2 weeks. That's the kangaroo mother care and prone ventilation.
Fantastic.
And the baby started improving. We started steroids, and after 2 or 3 weeks, we could extubate this baby. And this baby went home after like 95 or 100 days almost of stay, and came back for our World Prematurity Day at 1 year with a good outcome. Like slight delays, but very good outcome, good lungs. We have nice photos with this thing. So, you know, so we went.
Inspiring.
So inspiring
because when I heard both the stories that you mentioned, and you know, I could sense the amount of course you're a clinician, you're a hardened intensivist, but the challenges that you must be facing on one side and the rewards when things go well on the other side. And I mean, it keeps us going, you know,
it's
the rewards.
It's amazing. But there are so many learning points, like from each of these two stories. I was, in fact, when you started the second story, I was still thinking about the first one.
Yeah, I know.
Because I'm thinking about 350 grams, like what does that mean, 350 grams? And to be in a position where you have to say first yes or maybe. And then go and
last chance, your last chance of your life for the family,
and then make it into a no is
very difficult.
A very tough situation.
Very difficult.
Very tough situation.
So, do neonatologists, or you know, in the intensive care, the nurses, and you know, what sort of care do you do to prevent burnout in these situations?
Right.
Because it must be stressful. For burnout is when, of course, doctors and nurses get stressed out, and it affects performance. It affects us personally.
So yeah, I mean, burnout, I mean, physical and mental burnout. So physical burnout can happen in intensive care if, again, you know, there are longer working hours and intense commitment from the nurses and the doctors. But sometimes there's a mental burnout, you know, like whatever you say, that you get emotionally connected with the babies.
Yes.
And with the ups and downs in their situation, you do get emotionally traumatized to some extent. You get connected with the families as well. So, and we do feel bad when, you know, babies don't survive, especially when you have put in a lot of effort. Sometimes it has happened, 2 months the baby was with us, we did everything, suddenly an infection episode and baby gone. So, you know, we feel bad and it is stressful. And those who are facing that final moments, they feel stressed out. You get like those PTSD, post-traumatic stress disorder kind of, you know, those memories, flashbacks when you sleep. So again, I mean, we generally ask sisters to take a break. You know, going on holidays actually helps. You know, you just completely cut off from the NICU and come back. Good working hours and good working environments makes them.
Yeah, very important point. I think the work environment.
Work environment. So
culture.
Again, no blame culture. You know, so make it like a friendly and environment and talking to each other and no hierarchy and that kind of thing. You know. And then having some team building units, events, like we had a Christmas celebration at my home. You know, we had 28 nurses coming at my home and we had some celebrations. So those moments actually eases out things and removes the stresses. So I think we have to try all the means of supporting the nurses. And then there are always some nurses are a little bit more emotional than the others. So sometime again we used to call the palliative care team to do some debriefing sessions. So that's again useful.
So we did do a few debriefing with both the ICUs. I remember, and some of it was in the form of what we call as a death audit, where a child who has passed away just discussed the case. Usually, this is done in a medical. From a medical point of view, as in what more we could have done in terms of ventilatory support or medications or antibiotics, but the format that we had used was just allowing everybody to sit, talk about the recent death that they had faced in the unit, and just vent feelings. Sometimes people find it just hard to deal with death.
Absolutely.
Because I remember just having a death in the family may in the few months before, say, you have had this experience, may really impact your emotional state of mind. And so definitely everything that Kiran has said about taking breaks, family time, holidays, but also what you can do in the hospital environment. The other thing I know is what the atmosphere of the ICU was when he was there. I remember walking into the ICU and seeing it was a joyful, cheerful atmosphere. I think the no blame situation really helped. Reducing the levels of hierarchy, you cannot eliminate it, but at least reducing the levels of hierarchy to the extent that anybody feels that they can speak up and say what's wrong.
Because it's a team and everyone brings value. There's some value that everyone adds to that whole conversation.
Feedback given in a more palatable way. That all these things I think helped a lot.
It's a very important lesson in this conversation that I guess, if someone's listening and from the critical care space, I think it applies universally. The work environment.
Totally. Like, for example, also having a happy experience, a good experience, like the second story that you shared. So if a team has gone through a story like the first one, and then after that also you have had a good second story after that, even that is such a morale boosting kind of feeling.
So we should celebrate the success as well.
Celebrate the successes. So this is something that like if I link it up with what we used to do as palliative care, as the palliative care team, is always speak with families about let's hope for the best, but let's also prepare for the worst. And we call this something as, this is known as parallel planning, but how we speak about it as families, with families, is that we are really hoping, praying and doing all that we can to get the baby out of the NICU. But at the same time, let's also talk about what happens if that doesn't happen.
Yeah, so basically care never stops. So the whole emphasis is that care never stops. Regardless of how we are all there to ensure that there is good care, good quality of life for everyone concerned.
Absolutely.
But sometimes it's difficult for family to get disconnect, take that decision because so much of effort has gone in, so much emotional involvement is there. So it's not always easy for the families to come up with that conclusion and consensus to, go for redirection.
Because I remember the case that we recently saw together, where we planned a redirection after, I don't know, how many weeks in hospital?
I mean, that's again interesting. This is a baby who we actually retrieved from Bhusawal, like almost like 10 and a half hours one way. So almost 24 hours it took for us to go get the baby and come back. And this baby was in the ICU there for almost 2-3 weeks. And the issue was they were not able to extubate because baby's breathing effort was not good, and baby was dependent on the ventilator, and they didn't know the cause. And there was no imaging was done because there was no facility for the ultrasound, and baby was too sick to shift for an MRI or CT. So it was thought to be a respiratory, and we thought maybe an airway issue. So we got it, and we have a good services. So we got the baby with so much of effort. And when we got the baby in the NICU, and very first day only when we looked at the head scan, there was a fluid field around the brain. So it was a very small brain with completely like a extradural fluid collection. So small brain with complete full of fluid. So obviously we looked at airways and other things which could have been caused, but ultimately it was pointing that the brain was the issue. Yeah.
Correct.
Obviously, the MRI was done, and it was very evident that this is a brain which is not, it's an atrophic brain which is not developed.
Okay.
And that's why the baby's breathing effort is not great
So it wouldn't have been able to survive in a natural
way without a ventilator. Now, the amount of effort, almost 4 weeks happened by that time. The family has given up everything. They have come with so much of hope to us. And then we are saying that, okay, there is no outcome for this baby. It's better to go for the palliative care pathway.
Correct. So I think that's also where fundamentally medical thinking is aligned with. So I was just discussing this with someone that we just define outcomes as success or failures based upon different parameters. But the amount of effort that all of us have put into this, to do all that we can. So when you hear about all of this, I think it's a continuum. We can't. Things don't go well, we still, despite the best technology in the world, despite the best facilities, still there are people who die, and there are people who may not make it, and the question is, are we prepared for it? So that's why I was like very happy to hear your observation that that seeing a functioning palliative unit meant that nobody's abandoned. You're not like ab kuch nahi kar sakte ghar mein. That kind of an approach isn't there. There is that reassurance.
And the family needs now help at this point. What
They
to be
need
done?
that help.
They need
Correct.
that help now. What to do? So that's where I think palliative care services come. We have to show them the path. We have to tell them what options they have, and we just can't be stuck on the ventilator forever.
So we need to have some care continuity going on. As a team, this
You have worked in different. You have worked in different settings. Say this baby came to you in Canada or in Australia. What do you think you would have done?
This baby,
The one we just discussed.
yeah, well, I mean, we would have we would have offered palliative care. I mean, maybe if resource constraint wouldn't have been there, whether we could have tried to extubate the baby on NIV and maybe give some more time to the family rather than what we end up doing here little acutely. Because sometimes some of the neurological outcomes, and the baby's brain is neuroplastic, so there's basically they can still regrow, and when you're not sure, we generally tend to give longer time. So maybe there I would have probably spent a bit more time to come to a consensus, because financial or resource constraint wouldn't have been there. Correct. But here I think we I think end up deciding that fairly soon.
Fair enough. We have to work in the environment that we work in. I understand that, because sometimes we have these discussions on social media and many health spaces. They say, oh, this medicine is available. But then we have to be realistic that this medicine, if it's not available here, it might as well be somewhere on Mars.
Yeah,
You can't
correct. You
access
can't
it.
access it.
So you did well. I just want to flip this question a little differently now. Had you encountered this same situation, say in Canada or in Australia or in New Zealand, what would the reaction of the families have been as compared to the reaction of families here? You told us about what you would do things differently. Would the families' reactions be different?
Again, I mean, see, there's no scanning done at all, no investigation situation doesn't happen there, because baby would have been investigated well. They would have in fact questioned why this has come up so late. But again, the acceptance might be more there. I think the families, again, educational level is different, the environments are different. A lot of trust also on the healthcare overseas there. Here, I think a lot of time questions, there are doubts, because sometimes they come, especially when they come from different environment, there's a lot of mistrust happening in the previous place, because they feel they're not been like maybe full care was not given.
Emotional part. Life,
so they go to that lot of emotional turmoil here, and there probably they might have been guided from there, so the decision might have been easier for the families there, and they would have probably gone either ways. But again, as I said, they would have asked us to try a bit longer. I think because it's again not easy for the family to come to a conclusion so quickly, especially when the attachment is there.
So what you're saying is the resources make the trial period might be extended. But when it comes to the final decision making, that all right, Now we need to just focus on support.
Yeah.
Then that process is made easier there
There.
because of the support
system.
And here multiple factors play a role.
Play around, yeah.
Is it also to do with how families accept that a child may not grow up to be a so to speak normal child or disability in a child?
I think that's very important. In India, I think there's a lot of pressure about having a perfect child. So I think the acceptance for disability in overseas is more, again, because support systems and they take it as it comes.
Such an important point that you mentioned. Yeah.
So here, like nowadays, like people want one child and they want a perfect child. They don't want any disability. The acceptance is very less. And even if you tell them there's a 10% chance, they're like, oh, 10%. That's, they, it's like looking at the glass half empty or half full. They always look at the half empty part, and that sometimes becomes challenging here. So they will ask question, you give 100% guarantee. They ask us to give it in writing. And nobody can give right. Nobody knows, right? Many times you just have to live it over time.
Medicine is so humbling.
Yeah, so humbling. So there, I think that was easier. Acceptance was more, and here plus government is paying. So that again, questions are less. Here, like you're paying out of the pocket, so you want guarantee. It's always value for money. Okay, I'm paying you this much, then you give me a guarantee that my child will be perfect. And nobody can do that. So we feel a lot of pressurized in such situations.
And did you share the same kind of experience when you were dealing in the public sector, when you were working in the public sector in India? Because you have had a huge experience base. You worked in the public sector, the private sector, and in many countries. So
I think in public sector, and again especially the tertiary trust hospital was a like final destination for many places. They know that there's nothing beyond this. So when you offer in such this options in that situation, acceptance is more easier because they know there's nothing beyond this. In private, maybe they might do doctor shopping. They might just want to go and take a few more opinions, and they will question you. So yes, it does make a difference. I think in public setting or it might be a little easier compared to private settings.
So now again, that's interesting because we just thought about how the acceptance in India. I also believe now that in the public sector, the acceptance might be a little more
stronger, easier.
You can compare it with
But I also feel that I do agree that if you look at it from an ethics point of view or from a resource point of view, we have things which are very different in our country. Paying out of the pocket makes a huge difference. And there isn't enough, I would say, literature, medical or otherwise, that addresses how this changes healthcare. Whether it is public, you still end up paying out of pocket. Whether it is private, you still end up paying out of pocket. But what I have seen is that many a times, even though trust may be less earlier, you do your bit, knowing that you are giving all that you can, and also knowing at the same time that there are some things that you can't change. Remember, I think we have had this discussion many times when caring for patients, that there are literally some things where it's not the baby or the child which is at the center of the care. Like the child is not the central unit. It becomes that the family is the central unit. And this is very different from the individualistic approach that many Western countries have. But this is our reality.
This is our reality. So we cannot have an exact Western template to our settings. We have to have a little bit of mindfulness of our cultural settings and our resource settings. So yes, a lot of factors play. And again, private versus public, that difference is there. So I think every unit has to design for what suits for their unit. But I think awareness is more important. So I think I would again say that you guys are doing fabulous job, because a lot of time the clinicians are not even considering this, involving palliative care services or how you can help the families with joint decision makings. And sometimes the families are stuck. They don't know where to go.
So we don't work. We just do podcasts.
Maybe you should start working.
That's how unemployed we are. Palliative care.
No, so one more question I have before we finish is that what about discussing with families before the baby is actually out into the world? There are some situations where we know that there could be something wrong.
So are you involved, or is it an obstetrician driven decision making in India?
Yeah, I mean, thanks
And
for
the best.
asking this question, because this is another difference I found when I came back to India. So this is called as perinatology. So now we
Perinatology is around the birth
around
period.
the birth time. So just before birth and then around the birth time.
time.
So now we were thinking that we are also perinatologists when I was trained overseas, because that was a part of the training that we had to go for antenatal consults and talk to the family, prepare them, what's coming for them. And
so you're
counseling.
involved in those
In
discussions.
those discussions in Western world. Here, again, a lot of time the obstetricians take up the role of talking and explaining, and they do fabulous job. But obviously, there is a limitation. Certain conditions, I think neonatologists probably can explain better. They do involve surgeons for surgical condition and probably cardiologists for cardiac conditions. But as a neonatologist, I think we can do much better job, because we can prepare the family for the whole journey, what is signing up. Like suppose a premature baby is, then we tell them that okay, around 3 months of stay, what we'll be doing immediately after delivery, what complication, what are the outcomes. And again, the science has changed a lot in last 10-20 years. So there's a lot of positive outcomes which can be given, and the family wants to hear some positive things,
absolutely,
right? So we don't want to just depress them. Obviously, I think when we come in before delivery, it helps morale boosting, and we prepare them. Plus, we make a connection.
This trust is established.
And then it's easy for us to care after the delivery. And many times our families are like completely sorted if they know what's coming. Then they
it reduces anxiety to a large level.
Absolutely. In fact, just to we used to show them the NICU also, like, which I'm trying here. We take them in the unit. Okay, this is where your baby will be. You see, there is a similar baby, like a premature baby who's doing well now, 4 weeks down the line. So you show those stories, and actually it reduces the anxiety.
Yeah, because there's so much fear, and especially, and just forget, even doctors who might be going through these situations will be anxious. When it comes to parent, it's going to be very anxious for the first time seeing all of that.
Absolutely.
Because the uncertainty is a lot, right? You can only postulate that this might happen. You will not be able to actually, the only way you will know is when baby is out into the world. Correct. Is this also where the let's hope for the best but prepare for the worst
policy works? Yeah, this is what we exactly tell them. Yeah, hope for the best but prepare for the worst. And we give them the facts and just be positive.
And it's better to be prepared, better always to be prepared.
Yeah, absolutely.
The reason we are out of jobs is because he's doing all the palliative.
He's doing a lot of palliative care already. Great, So before she goes on to the thanks, now one more podcast will do. Thanks. So before we go on to the last couple of questions, I just wanted you to kind of tell us in brief, what are the things that you are doing now in your private practice in India, which I can say I can expect anywhere in the world, I'd say, okay, this, I don't have to go out of India for this. I know that this is available here now. Is there something that you're doing, that's something you'd like to share?
Sure. So, I mean, the current place, I feel very fortunate that the hospital which I'm currently working is a state of the art. It's built in collaboration with Sick Kids Toronto, where I used to work. And this hospital infrastructure is not less than any hospital in the West.
And how many floors do you have?
6-7 floors, and probably they're planning to extend another couple of floors. And state of the art.
Just a children's hospital.
Just children's hospital with all super specialty, pediatric super specialty in-house, and very spacious ICUs, n number of outpatient theaters. We have in-house MRI, CT scan, fluoroscopy, cath lab,
all in one.
Everything in one roof. And the best part, it's designed for family-centered care. So there are on the ICU floor there is a lounge and a sleeping lounge for the families to stay. So in their difficult time, when the babies are in ICU, we let them stay for free, and they are close to there's no restriction for them to come in and out. And we are very a transparent care. They know exactly what's going on, and they are in fact involved in the care. So they come in. So mothers stay almost with us for 2-3 months, and then they're doing like kangaroo mother care. They're helping in feeding, helping in care, and they're staying there. So no stress for them. And I mean, again, there were new things we started. Finally, starting palliative care services in this place also was one of the challenge. Again, taking administrators on the board, all clinicians on the board, because we we are a referral hospital, so we have referred lots of complex cases from the beginning only. So we end up palliating 3 to 4 cases where we involve palliative care services, and so that was also a new challenge. So I would boast that there's nothing really less we are doing than Western world, and we're going to soon start the cardiac services and also ECMO services, which is still not there. But already the bone marrow transplant has started, and liver transplant, I think they will be starting in pipeline. So
job check, yeah?
So definitely, I think I can proudly say that within a span of 1 year, we just completed last week 1 year, and around 250 cases in the ICUs.
Lovely.
So with the good outcomes.
Lovely.
So
that's very heartening to hear. Absolutely.
Yeah. Good job.
There's more strength to you. Wish you all the best with all of that, because it's so much needed when you bring all this expertise from all over the world and you come back to India. And I was telling somebody, people, I won't mention names, but someone asked me, why are you coming back?
Correct.
Someone asked me, why are you coming back to India?
I
So
know.
these are the reasons why you should be coming back.
Correct. Wait, we should have a reverse brain drain now.
Yeah,
not ever. Yeah, we should have all the good brains coming back to India and help us.
So
I'm much honored and obliged to be sitting with 2 brains.
absolutely.
Welcome back.
Trained themselves back in India.
That's 4 because हम 2 के बराबर हैं. Just want to ask him the
Yes. So this is the question that we always ask all our guests. What does living well mean to you?
Living well, when having a good healthy life, that's what I feel. Healthy mind in healthy body. So you should all work towards having a healthy life. That's what I think we were. I anticipated. Initially, I thought it's a living will. We are going to make a will before dying. But yeah, I think. वो भी करना चाहिए. But yeah, it's, I think, the holistic care of the well body and a well mind. Probably this is what something. Maybe I would like to know why you named that, coined this name.
Good
the
question.
has come back to us.
The questioner becomes the questionee. No, I think the whole idea is because when we talk about palliative care and we discuss palliative care, we are often looking at the relatively darker stories and sadder stories, but there's so much positivity that we have heard in so many podcasts that we've seen. Every person we meet has come up and given us something very inspiring. So that's I think that the beauty of all of that is we continue to live well, and even in the darkest times or the most difficult times in people's lives, there is so much strength. There is so much humanity, shared humanity. There's so much, and every time I do a talk with people and I discuss these things, I get to learn so much, and I just feel personally very obliged and grateful that that we came up with this thought process, and it's really good. Anything, Smriti, what do you feel?
My thought process is that living well includes dying well. Death is a natural part of life. We have medicalized life to the extent that now it is on us to know when it is time, make sure that it is done well, it is done with dignity, and it is done with minimal amount of suffering.
So it's living well all the time,
So it's living well all the time.
So I think that's
till the end of your life.
So that
better way.
And the funny part is, of course, when we came up with this name, at the end of the day, when we realized that there are like 500,000 podcasts on which are living well.
Because everybody
wants
has
to
the idea.
People like, what a brilliant idea. Living well. There's like 150 million living wells already. So thanks. It's been a great
Thank you so much.
interaction.
Thank you,
Thanks.
Kiran.
And wish you all the best with your work, Kiran.
Thank you. Thank you for
Thank you so much.
calling me. Thank you.
Thank you.